7%, and the PaO2 is 37 millimeters of mercury. On the other hand, if you have a white baby, here the PaO2 might be 52 millimeters of mercury. The difference is that this baby's saturation falls in the hypoxic pulmonary vasoconstriction range, whereas this baby's oxygenation falls in the normal range. And so this difference might contribute to a higher incidence of pulmonary hypertension in babies that have dark skin pigmentation. And so that's something for you to keep an eye on in babies. So what is very interesting in the US is that white babies have a lot more ROP, whereas black babies have neck and PPHN that's much more common. It's possible that just because we focus so much on pulse oximetry, we tend to probably expose black babies more to hypoxemia and white babies more to hyperoxemia. And so diseases that are associated with hyperoxemia, such as ROP, are more common in white babies with light skin pigmentation, whereas diseases that are caused by hypoxia, such as PPHN and necrotizing enterocolitis, are more common in black babies, where hypoxia is more common. So let's move on to a fetus as to how a fetus survives. The big question that actually led me to research in this area when I moved to the US was, if you go and put a pulse ox on a fetus, I do a lot of lamb studies. I have an interesting story that I'm a vegetarian who has never touched meat, but I do all my research in animals, which is a story for some other day. But what I see when you take a fetal lamb and put a pulse oximeter on a fetal lamb is that the saturations in a fetal lamb are around 58 to 65%. That's the saturation of a fetus as well. A fetus has a postductal sat of around 58%, a preductal sat of around 65%. On the other hand, once this baby is born, even a premature infant born at 23 weeks will not survive at such low saturations, and they need SAT somewhere in the high 80s to 90s. Why does this happen? Why can a fetus get away with such low oxygen numbers, whereas a newborn infant can get away with similar oxygen numbers? The reason for it lies in this organ, the placenta, and that's where the trick is. So I told you the difference between hypoxemia and hypoxia earlier. So a fetus is a classic example. A fetus is hypoxemic, has low PaO2 compared to adult standards, but is not hypoxic. It has no problem in delivering adequate oxygen to its tissues. In fact, a fetus weighs a few grams when it's as an embryo, and it grows on to become a 3.5 kg baby. And all this growth happens with an oxygen saturation of around 65 to 68%. So a fetus is definitely, a normal fetus is not suffering from hypoxia, although the PaO2 levels are really low. The reason for this is that the site of gas exchange is the placenta and not the lung. And the placental circulation is not subject to hypoxic constriction. Only the lung circulation is subject to hypoxic constriction. So for this reason, a fetus does not care about hypoxemia and can continue to deliver adequate tissues. The second thing to notice is that if, let's say I do a blood gas on one of you, your arterial PaO2 is around 97 millimeters of mercury, assuming that you are not a smoker, and your venous PaO2 is around 40 millimeters of mercury. So to deliver 4 ml of oxygen per 100 ml of blood in your system, you have to oscillate between a PaO2 of 97 and a venous PaO2 of 40. In other words, 57 millimeters of mercury. You have to go back and forth with every circulation to deliver 4 ml of oxygen to your tissues. On the other hand, a fetus can deliver the same 4 ml of oxygen to her tissues, basically having an umbilical venous PaO2 of 35 and an umbilical arterial PaO2 of 22. So the fetus is very smart. It delivers the same amount of oxygen, but does not expose itself to any hyperoxia by having very low PaO2 values. And that's the reason why a fetus is hypoxemic, but not hypoxic, because the delivery of O2 is similar to that of an adult. In fact, I call a fetus a perfect parasite. So I apologize to all the mothers in the audience, but a fetus knows how to extract every bit of nutrition from the mother, including oxygen. I'm sure you come across many parents, many mothers who have hemoglobins in the 4 grams per deciliter range. And when their fetuses are born, those babies tend to have hemoglobins in the 10 to 12 range, suggesting that even though the mother is deficient herself, she continues to sacrifice and give all her nutrients and oxygen to the baby. So that's how motherhood is, as we all know. So the fetus is a perfect parasite which gets every bit of nutrition, including oxygen from the mother, even though the mother is partly deprived. And that's the reason why even if fetuses born to mothers with various medical conditions tend to look relatively okay. That's because they're able to suck out all nutrition that they need from the mother. Okay, let's move on to neonatal resuscitation, which is the hot topic at this time. So oxygen is the elixir of life, and I'm sure all of you have seen a baby looking blue and pale in the delivery room. You walk in there with oxygen and then give oxygen to this baby, and the baby turns pink right away, which is basically the goal of oxygen resuscitation. And we as intensivists and pediatricians and neonatologists and even obstetricians, we all love oxygen, and many of us trained, including myself, with the early editions of NRP, where the use of 100% oxygen was universally recommended. And also there's a big culture on why oxygen should be used. In the US, there's a magazine called Oxygen. There's a movie called Oxygen. There's a guy called Mr. Oxygen who keeps on writing books. There's actually a TV channel called Oxygen. You find a lot of these things about oxygen, and every time you talk about oxygen, it tends to talk about positive virtues of oxygen. On the other hand, carbon dioxide gets a very bad reputation. I can guarantee you that there is no movie called Carbon Dioxide, or there is no TV channel called Carbon Dioxide. And anytime the carbon dioxide comes in, all negative things are talked about: allergies, asthma, fatigue, snoring, stress, panic, IBS, etc. They're all attributed to carbon dioxide. But we all know fully well that as important as oxygen is, carbon dioxide is equally important, because if you don't have adequate carbon dioxide levels, your blood flow to the brain tends to go down. So hypocapnia or hypocarbia is a common cause of cerebral hypoperfusion. And so having adequate levels of CO2 are really, really important as well. The other reason why we tend to be attuned towards using more oxygen is basically the UPCAR score. As you know, the UPCAR score assigns 0 points for being blue or pale, 1 point for the body being pink and the extremities being blue, and 2 points for a baby who is completely pink. And this number is assigned at 1 minute after birth. We know fully well now that every single fetus that's born at birth at 1 minute of life has an oxygen saturation of somewhere around 65 to 70%. And so they're all blue and pale. So being blue at 1 minute of life is normal. If the body is pink and the extremities are blue, this is perfectly normal acrocyanosis, and there's nothing wrong with it, except that maybe the baby's extremities are a bit cold compared to the rest of the body. And being completely pink at 1 minute of life is actually pathological, and it suggests that you're giving too much oxygen to this baby, or you are colorblind, one of the two. So this has led to this craziness about scores. I know many of you work in Hyderabad and tech cities and have a particular affiliation. I live very close to the Silicon Valley here in the US. So many of the mothers I care for are work in software, and they are very particular. They have an app where they want to enter the baby's UPCAR score. And if I tell them that the score is anything less than 10, they get very disappointed. So this is almost like a thing that's starting early in life, where every single score is important. As many of us know, you start off with UPGAR scores, and it goes on to various examinations that you take. And every single exam has a score. And similar to that, parents become very, very preoccupied with what the UPGAR score should be in their baby. And any number less than 10, they get disappointed. But we now know fully well that even a normal fetus, when it goes through through birth with 21% oxygen, there's a significant increase in PaO2 at birth. A fetal PaO2, as I mentioned previously, in the umbilical arterial line is around 25 millimeters of mercury. A baby's PaO2 after birth is around 50 millimeters of mercury. So there's a 2.5-fold increase in PaO2 values, even with breathing room air. And this results in a short surge of free radicals in the body. And it tends to go away, but there's a short surge of free radicals when you measure it biochemically in these babies. On the other hand, even if you give 100% O2 for a transient period of time, for a few minutes, this causes a huge increase in PaO2. You can achieve a PaO2 of close to 500 millimeters of mercury by giving 100% O2 in the delivery room. And when this surge happens, you tend to see a huge increase in 100% oxygen free radicals. And these free radicals can stay in the body for a long period of time. And people have measured blood and urine at 28 days after birth and still found evidence of biochemical evidence of free radicals in the blood following use of 100% oxygen in the delivery room. So we know in term babies, all these data are in term babies. In term babies, there is increased brain inflammation, there is increased incidence of hypoxic ischemic encephalopathy, there is increased incidence of myocardial damage and acute renal injury, and in some studies, increased incidence of childhood leukemia by using 100% oxygen in the delivery room. And when you pool all the studies together in term babies, the use of room air for initial resuscitation compared to 100% oxygen, when the pool data suggests that there is increased mortality with the use of 100% oxygen as well. So how on earth can use of oxygen in the delivery room cause leukemia? What's the link between these? That's a very interesting question. But before we go to that, I want to remind all of you that this is what happens in term babies. So in term babies, we know fully well that we should resuscitate air with 20, we should initiate resuscitation with 21% oxygen. But what about preterm babies? These studies don't really apply to preterm babies, especially extremely preterm infants. So this is where the fact that one shoe fits all or use of 21 or 30% oxygen for all gestational age groups doesn't work out well. And as many of you know, when the term studies came back showing that we should use 21% in term babies, we all jumped on the bandwagon and reduced the initial oxygen to 21 to 30% for preterm babies as well, which resulted in increased mortality in extremely preterm infants. So that brings us to the only question I have in this talk. It is, let's say you are on call tomorrow, and then you're called to your delivery room where there's a 26-week gestation baby being born, and the baby's estimated birth weight is 650 grams. What is the initial oxygen concentration would you use for the initial resuscitation of this baby? If you can put your answers in the chat, or if you unmute and answer, that would be awesome. So the choices are 21%, 30%, 60%, and 100%. And I'll take a pause for a second and monitor the sets, monitor your answers.
Sir, are you able to see the answers?
Yes, I can see the answers. So Dr. Suguna replied 30, Dr. Karan Kumar 30, Haritej said 30 as well, Rajesh Kulkarni 30, Dr. Dawa 30, Dr. Ashok B. Okay, Dr. Nikhil Kumar said 100%. Dr. Prakash Manikot, hi Prakash, said 30, and Dr. Chandramohan said 31. Okay, so it's a high range. Dr. Anil Kumar has recently read the book and he said 30 to 100. So, okay, so we have a wide range of choices. So the honest answer is that we do not know. We really do not know how much oxygen to use in these babies, and I'll walk you through some of the controversies here. Thank you for actively participating. So I'm not sure if there's a new version of this book yet, but I received a copy of this when I was in Vizag, and I realized this book had guidelines basically saying that in babies less than 35 weeks of gestation, we should start ventilation with an oxygen of 21 to 30%, which is what was recommended in the NRP 8th edition as well. So those of you who chose 30% based on the 8th edition, that answer is correct. And the 1% among you who chose 30 to 100%, that's the right answer based on the 9th edition. But why are these guidelines so confusing and changing? So the whole concept started with many studies, but this is one of them. This is the first torpedo trial, and this is Dr. Julie Oye. And what she did was she did a trial comparing room air versus 100% oxygen in babies. And in that particular study, when she looked at data from babies less than 28 weeks of gestation, what she noticed was that there was a significantly increased number of deaths in babies who were initiated resuscitation with room air compared to those that got 100%. And this caused a bit of an alarm because this p-value was less than 0.05. And interestingly, majority of these deaths were due to respiratory failure. 8 of these deaths happened due to respiratory failure in the room air group versus 1 in the 100% oxygen group. So around the same time, people in Canada started reporting that ever since they changed guidelines, moving away from 100% O2 to 21 to 30% O2 for all infants, although the term infants were doing well, the preterm infants had increased mortality and poor outcomes. So this resulted in lots of concern about the use of 21% O2 in extremely preterm infants. More reasons. So what's the difference? What's so different about preterm babies? Why are they not like small term babies? So preterm infants, especially those below 25 weeks of gestation, are very unique. And the general rule in preterm babies is that if you can't achieve a saturation of at least 80% by 5 minutes after birth, the risk of IVH and the risk of death in these babies is very high. So every single baby that you go to a delivery to, If the baby does not achieve SATs of 80% by 5 minutes, that baby's outcome is not going to be good. So why can't we achieve a SAT of 80% by 5 minutes? The biggest challenge here is that the mask does not fit well on the face of preterm babies. Preterm babies don't have the nice fat pads that term babies have. So the fitting the mask is not very easy, and there's a high chance of having mask leaks. In addition, their RDS is pretty severe. The surfactant deficiency is pretty severe. So you need fairly high pressures because the lungs are not as compliant as usual. These two facts lead to low alveolar PaO2, where you use a capital A, PaO2. This number is low. Even if you're using 30% oxygen here through the TP's resuscitator, not much is coming down to the lungs because of all these factors. The other issue is that the distance between the air sac, remember these babies are still in the canalicular stage of lung development. They don't even have alveoli. So the distance between the air space and the capillary, this interface is poorly developed and the distance is quite wide. And this results in poor transfer of oxygen from the alveolus to the pulmonary capillary. In addition, the pulmonary vascular smooth muscle does not respond well to oxygen, and so it doesn't dilate as much as a term baby's pulmonary artery. And as I mentioned previously, these babies are immature, they have surfactant deficiency and fluid-filled lungs. And finally, these babies are a bit sensitive to what is called as the trigeminal cardiac reflex. When you put the mask, if you press too hard on the face, that pressure can itself cause bradycardia in some babies. In addition, if they're exposed to hypoxia, normally hypoxia is supposed to stimulate respiration, but in babies, especially preterm ones, hypoxia tends to close the glottis and reduce respiration, and this is another problem in these babies. So the combined effect of all this is that there is poor pulmonary vascular transition and higher incidence of respiratory failure with inadequate oxygen use in preterm infants, and that's a big problem in babies, in extremely preterm infants. So more recently, Dr. Julie Oy, the same person I showed you in the previous slide, did a repeat study looking at 30% and 60% oxygen, which was just released a few days before the NeoCon in Vizag. And what she showed here was that she compared 60% oxygen to 30% oxygen, and basically there was no difference in outcome. In other words, the absolute risk difference was not different, and there was no difference in any of the outcomes in this particular study. So giving 60% oxygen was not adequate to correct or improve mortality compared to 30% oxygen in these babies. In the meantime, Dr. Janneke Decker did a study from Europe where she looked at 30% oxygen versus 100% oxygen. It's a small study with only 44 infants compared to the Torpedo trial, where you have close to 1,500 infants. This is a small study, but in this small study, what she showed was that giving 100% oxygen initially with rapid titration resulted in higher minute volumes, shorter duration of mask ventilation, higher oxygenation at 5 minutes, shorter hypoxemia, and higher FiO2 during the first 5 minutes. So she showed all these real improvements. And she showed no difference in the duration of hyperoxemia. And they looked at an oxidative stress marker called as 8-PGF2 alpha. And that oxidative stress marker was not different between the two groups. But that stress marker is not a very sensitive one, so that might be one of the reasons. So in other words, there were benefits in using 100% oxygen in this particular small study. So subsequently, a meta-analysis was done where a lot of babies were pooled. And what they showed, bottom line, is a very complex slide, but this includes 12 randomized trials with close to 1,000 preterm babies less than 32 weeks of gestation. This study did not include the more recent Torpedo trial. And what it showed was that when you compare 21 to 30% oxygen, low oxygen, to high oxygen, 90 to 100%, the risk of mortality was significantly lower with the use of high oxygen. On the other hand, if you used intermediate oxygen, 50 to 65%, there was no difference at all. So this was not adequate, whereas this made a difference in reducing mortality. So this led to a lot of confusion while writing the NRP books. And that's the reason why you have this wide range of 30 to 100%, suggesting that we really don't know the right answer as to where we should go from here. One other challenge is that I mentioned to you previously that by 5 minutes, you need to hit a SAT of around 80%. So this is a data from California, but one of my colleagues did this trial, and we also participated in this trial. What it shows is that the green color here and the yellow color here suggest appropriate oxygenation. So the green is the right zone you should be in by 5 minutes after birth. And in this particular slide, what you see is that at less than 23 weeks of gestation, this is when you start off resuscitation with 30% O2. Very few babies attain appropriate oxygenation of above 80%. So 70% of babies do not attain adequate oxygenation at less than 23 weeks. And even at 24 weeks and 25 weeks, this number is fairly high. So you see that at extremely low gestational age, especially less than 23 weeks and less than 25 weeks, attaining adequate oxygen saturation by 5 minutes does not happen with initiating resuscitation with 30%. On the other hand, at 27 and 28 weeks of gestation, more than half the babies attain adequate saturation. So this is not a problem. Only these groups are a problem with this particular approach. So this led to a concept that we call as the Doxy concept, where many of us practice deferred cord clamping. And this concept is that when the baby is still attached to the placenta, give the baby 100% oxygen. The difference here is that this 100% oxygen helps open up the alveoli and stimulate respiration. This 100% oxygen also opens up the pulmonary vasculature, causing pulmonary vasodilation. But by the time the blood reaches the atrium, left atrium, there is blood coming back from the umbilical vein that crosses the PFO and joins the left atrium. And this blood coming back from the umbilical vein only has a SAT of around 80 to 85%. So this oxygen comes and mixes with the oxygen coming back from the lung. And so although there is local hyperoxia causing pulmonary vasodilation, there is no systemic hyperoxia because the umbilical venous blood is diluting and reducing the PaO2 in the systemic circulation. So this concept is called as the Doxy concept, and this is where during deferred cord clamping alone, when the baby is still attached to the placenta, you use a mask and give 100% oxygen, and then the baby comes off, and then you reduce the oxygen down to 30% and ventilate. So we recently completed a trial that was published in JAMA Peds, where we looked at babies less than 29 weeks of gestation and gave either 100% O2 or 30% O2 during deferred cord clamping. And after that, all babies received 30% O2 with titration. And what we noticed was that the primary outcome of achieving SATs of around 80% by 5 minutes of life was 47% or 69% in the 100% oxygen group and only 39% in the 30% oxygen group. And the time to achieve SATs of more than 80% was much shorter in the 100% oxygen group compared to the 30% oxygen group. Remember, we are using oxygen only for 90 seconds here during DCC. Subsequent to that, we are turning the oxygen down to 30%. Interestingly, contrary to our expectations, severe BPD grades 2 and 3 was actually lower in the group that got 100% oxygen compared to the group that got 30% oxygen. So should we all jump and start using 100% oxygen in the delivery room? Not so fast. The problem with using 100% oxygen even transiently is shown in this graph. It's data from the same trial I showed you before. The blue bars here are 100% oxygen. The orange bars are 30% oxygen. As you can see here, with the use of 100% oxygen, even transiently in the delivery room, the SATs can be quite high fairly early, and this can result in some degree of oxidative stress. And so when we went back and looked at these babies, what we think is happening is that giving low oxygen by a mask causes hypoxia, which suppresses respiratory drive. That does not result in opening of the pulmonary arteries. So this results in a high alveolar to arterial gradient. And there is poor vasodilation. And for this reason, the right ventricle continues to have high pressure and the ductal shunt remains right to left. And that's the reason why babies don't do really well with low oxygen. On the other hand, if you give higher oxygen, the alveoli tend to become much more open, respiration is stimulated, the pulmonary blood vessels open up and causing pulmonary vasodilation, and the right ventricular pressure goes down and the left ventricular pressure goes up, and there is the shunt across the ductus becomes left to right, and now the baby has better oxygenation. But the problem with all this is that if you use high oxygen, you tend to have oxidative stress, which could be biochemical, or this could have more important consequences. So what are we talking about when we talk about biochemical consequences? I know this is a complex slide that takes you back to your biochemistry days, but let me just walk you through one simple fact here. Glutathione is a very, very important antioxidant in the body. So glutathione represented as GSH here gets converted to oxidized glutathione or GSSG by giving away these hydrogen protons or hydrogen atoms. So when this happens, when GSH gets converted to GSSG, that's when things go wrong. And when you have high oxygen hyperoxia, this tends to drive this reaction and converts more GSH to GSSG. The problem with this reaction going this way is that this can in turn cause peroxidation chain reactions. And the main concern here is that around the time of birth, this oxygen toxicity can damage your DNA. And this DNA damage can in turn result in the higher incidence of conditions such as leukemia, etc., in babies. So that's the reason why we need to look for biochemical evidence. Just because the baby looks good and nothing bad is happening, we can't just let go and start using 100% O2. We need to be careful and look for evidence of biochemical reactions like this because these are really important. As you can see here, if you have more GSH, that's good. If you have more GSSG, that's bad. And so this is the good thing and that's a bad thing. And so when we look at the GSH to GSSG ratio, having a low ratio means that there is high oxidative stress. So you'll start seeing more and more papers looking at GSH to GSSG, and that's a concern. So going back to the previous trial I mentioned you, what we noticed was that in the babies that got 100% oxygen, remember this is only for 90 seconds, just 90 seconds, and we draw an umbilical arterial gas, the GSH-GSSG ratio is only 7.5. Remember, low numbers are bad. On the other hand, if you give 30% oxygen, the GSH-GSSG ratio is 37. So higher numbers are good. So even exposing a baby to a short duration of oxygen tends to cause a big difference in the GSH-GSSG ratio. What does it cause? What's the problem with this? We really don't know. It's statistically not significant, but it's very concerning to me as a scientist. So we need to really do more studies looking at 100% O2 before we go ahead with it. So with that, let me quickly jump to a couple slides on what the 9th edition talks about, since many of you have switched over to the 9th edition of NRP. So as many of you know, the algorithm changed quite a bit. This is the 2020 algorithm over here. Here is the 2025 or 2026 algorithm. And there are several changes here that I would like to point out. One, there is a complete new box on initiating cord management plan. So this is really important. As soon as you walk into the delivery room, ask your obstetrician, what is the cord management plan for that baby? And this has to be discussed before the baby is born. You should have a clear-cut plan. That's really important. The second is that the importance on stimulating and clearing the airway has been reduced. In other words, you clear the airway if needed. In other words, if the baby does not require any clearing, the baby is actively crying, don't put a suction into the baby's mouth because that can cause bradycardia and problems. The third is tactile stimulation. Stimulating the baby is really important. And by stimulating a baby, you tend to induce spontaneous breathing, which results in negative pressure while crying. And if the baby cries, there'll be more transfusion of blood from the placenta. And so instead of giving positive pressure ventilation, stimulating the baby to make the baby cry is probably more important. The fourth thing is skin to skin with parent. This is something that you're all experts in. If the baby does not require resuscitation, then the baby should go to the mom, stay skin to skin with the parent, and bond with the parent. And then checking for chest movement. We used to put a lot of importance on chest movement, and now we are beginning to realize that if you really see good chest movement during PPV, that means that you're giving too much of pressure. So that emphasis on chest movement has been taken out. And in fact, you place more attention to oxygen saturations and heart rate in the baby. And then we increasingly realized that by 1 minute of age, many of us couldn't even get a pulse ox on the baby, and this number could be unreliable. So the 1 minute value was taken out, and now we start monitoring oxygen from 2 minutes. Although the numbers are still the same, we stop looking for oxygenation at 1 minute of age after birth. And then the laryngeal mask airway. I know it's not a common thing in India, but it's increasing in popularity here. And people now are realizing that instead of using a mask, at least in mostly bigger babies, using a laryngeal mask directly could be very beneficial. And so there is increased use of laryngeal mask airway in these babies. And then we talked about the FiO2. Now the current recommendations are more than or equal to 35 weeks, use 0.21. 32 to 34 weeks, 0.21 to 0.3, and less than 32 weeks, use anywhere from 30% to 100% oxygen. And there are some new guidelines for pressure as well. And the ventilation rate has changed from 40 to 60 to 30 to 60, and the initial PIP is higher in term babies compared to preterm babies. So these are all the changes in the new edition of the NRP. So let's focus on oxygen because that's the main focus right now. So based on NRP guidelines, as we said earlier, the goal is to get to a SAT of more than 80% by 5 minutes. So in term infants, you start with 21%, and then in 30 to 34 weeks, you use a range of 21 to 30%, and less than 32 weeks, you use a range between 30 and 100%. But I find these numbers very confusing. So in my unit, we are starting a study, which I call as the sliding scale. One of my colleagues, Evangisto, is doing this study. So what we do is 35 weeks and above, we still use 21%. For 32 to 33 and 34 weeks, we use 30% because there's a new trial that's coming out soon. I believe it's already published, where they have shown that using 30% oxygen is better than using 21% oxygen at this particular gestation. So we switched to 30% here. And then once you become preterm, based on gestational age, you tend to use initial oxygen. If the baby is only mildly preterm, 29 to 31 weeks, we use 40%, 27 to 28, we use 60%, 24 to 26, we use 80%. And if they're really, really tiny babies where we can get their oxygen sats up, we use 100%. But the more important thing than this is that you need to watch this table and titrate the oxygen by 20 to 30% every 30 seconds. So if the baby is, let's say the baby is saturating 60, but the SAT should be 80, we immediately change the saturation by 30%. So if the difference between the desired saturation and the baby's saturation is within 10%, we increase or decrease the SATs by 20%. On the other hand, if the baby's SAT is more than 10% away, in other words, the baby should be having a saturation of 80%, but the baby is only saturating 65%, the difference is more than 10, in which case we jump up the FiO2 by 30%. So these are big changes done very frequently so that we attain the SAT of 80% really fast. And if the baby is hyperoxic, we also reduce the FiO2 really fast. So there's a lot of titration happening here, and that's really key with these infants. So to conclude this section, it's like the Goldilocks and the three bear story. If you're hypoxic, gestational age influences initial FiO2, and tiny preemies may need higher FiO2. On the other hand, achieving more than 80% oxygen by 5 minutes is the goal, but also avoid hyperoxia with SATs more than 95%. So titrate the FiO2 relatively quickly to target SpO2, and this is the so-called Goldilocks and the three bear story of oxygen. I think in the interest of time, I'll stop here. I have a lot more slides on what to do in the NICU, but if there are any questions, I will take them and I'll show you those slides. And Dr. Lingareddy, if that's okay, I will take a break here and then answer questions.
Yeah, explains. There are some questions, sir. One question from Dr. Kalab Chandrapal. The role of HB in maintaining fetal O2 status.
Yeah. That is a wonderful question. So it's the question is, do you tolerate anemia? Where should you maintain your hemoglobin? That's a very important question. Oxygen delivery to the tissues is influenced more by the hemoglobin concentration and less by the saturation. So maintaining adequate hemoglobin is really, really important. But the problem is that if you retain fetal hemoglobin, in other words, if the baby's fetal hemoglobin is high, and you don't draw too much of blood from the baby and maintain the fetal hemoglobin higher, that's much more efficient than drawing a lot of blood and giving a transfusion with adult hemoglobin, because hemoglobin A is not as efficient as hemoglobin F for maintaining saturations. So in preterm infants, the top trial has shown that maintaining high versus low saturation threshold does not improve outcomes. So for that reason, there are new transfusion guidelines that have come out from the neonatal hematology group that are published that clearly mention how much hemoglobin you need to maintain based on whether the baby requires respiratory support or not. And so those guidelines are available. But if you have a term baby who is not doing well, especially those babies that are on the verge of ECMO and are really sick with PPHN, I personally tend to maintain a hemoglobin of somewhere around 12 because that baby requires a lot more oxygen. So in preterm babies, I follow the transfusion guidelines. In term babies, especially those that are really sick, I maintain a hemoglobin of around 12, preferably with fetal hemoglobin if possible, but if not, we give transfusions to maintain hemoglobin of 12 in these babies.
Sir, another question from Dr. Alvelu ma'am. What is the target SpO2 in SGA preterm babies?
Yeah, that is a really nice question. So let me share my screen just for a second. So this controversy about SGA babies came about because there was a study many years ago which looked at comparing SGA babies to AGA babies. And let me just share my screen. I don't have that exact study here, but the question is, oops, sorry. So the question is, what's the optimal oxygen saturation in preterm infants in the NICU? So the concern here is that if they're AGA or LGA babies, they tend to behave very differently from SGA babies. SGA babies are more prone to necrotizing enterocolitis and BPD and pulmonary hypertension, etc. So there was this thought that maybe SGA babies require higher oxygen, but subsequent trials and the NeoProm trial, the subsect of AGA babies did not show any difference. So even in AGA babies and SGA babies, we tend to maintain the same saturation. This is based on the Boost trial, which basically showed that when you compare babies with 85 to 89% saturations with 91 to 95% saturations, although most of the outcomes were similar, the mortality was higher in the lower saturation group, although ROP was higher in the higher saturation group. Because of the higher mortality here, we all have moved to this saturation. So we maintain sats between 90 and 94% in this particular group. So the wisdom here is that it's like driving a car. If the lane where you're driving is very narrow, it's tough to maintain oxygen in that particular range. On the other hand, if the lane is wider, it's much easier, and so it's much easier to set up alarms in these babies. So I personally use, instead of using 90 to 95%, which is very difficult to maintain, I tend to use a slightly wider range of 90 to 97%. So in preterm babies, I use a SAT of 90 to 94%. In term babies, I use a SAT of 90 to 97%. So let me show you a conclusion slide here. Sorry, I had lots of other slides planned. So this is my overall assessment on what to use and when. In preterm babies, whether they're SGA or not, the early postnatal period, you tend to use SATs between 90 to 94%. Once the baby gets past the early phase, and if the baby develops pre-threshold or severe ROP, and in this phase, I tend to use a higher SAT of 94 to 98% in these babies. On the other hand, in term babies and late preterm babies, I tend to use a SAT between 90 to 97% if they have PPHN. On the other hand, if the baby is undergoing hypothermia, during hypothermia, the problem is that the hemoglobin oxygen dissociation curve shifts to the left. Or if there is severe acidosis, or the skin pigmentation is really dark, I tend to use SATs between 93 and 98%. So avoid SATs of 99 to 100% because when you're on supplemental oxygen, that can cause severe hyperoxia. So the short answer to your question is whether they're SGA or AGA. Preterm babies in the early phase, they have SATs between 90 to 94%. Towards their late phase, this is when they're ready to go home, and if they really have severe ROP or severe BPD, in those phases, in the late vasoproliferative phase of ROP, we tend to use higher SATs because in this situation, exposure to hypoxemia can worsen ROP. So we tend to be a bit more careful in this particular age group. But for the most part, most of our babies have a SAT range between 90 to 94 in the preterm age group.
So question from Dr. Rajesh Kulkarni. How many percentage of newborns in your unit between 26 to 28 weeks manage in CPAP alone?
Yeah. So the population we care for is a little different here, especially if the parents get antenatal steroids and have good perinatal management. They tend to do quite well. So in my unit, 26 to 28 weeks, probably more than 50% of babies never get intubated. Sometimes they get LISA, which is less invasive surfactant delivery, either through a catheter or a angiocath. So a significant portion of them don't get intubated. But that's a population where the use of antenatal betamethasone is pretty high, like in the 90% plus range, and mothers are fairly healthy. If you come to a population where mothers are not very healthy or have various other issues, then the risk of ventilation is much higher here also.
Sir, another
Yeah,
question
a lot
from
depends on what the perinatal factors are.
sir. Another question from Dr. K.S. Sir. Sir, many anesthesists give 5 to 10 liters of 100% oxygen to the mother by mask at the time of during cesarean delivery, especially if fetal distress is there. Will it be harmful for the baby?
That is a great question. Anesthesia and NICU don't get along in any country. It doesn't, whether it's India or the US, doesn't matter. Anesthesia always thinks that babies in the NICU are hypoxic and dry. They always want to give, the moment they come in, they give a fluid bolus and they give a lot of fluids during any surgery. And I've seen this happen in India, I've seen this happen in Europe, I've seen it happen here as well. And they also tend to be very generous with the use of oxygen. So talking specifically about the mother, giving 5 to 10 liters of 100% oxygen to the mother tends to increase the fetal PaO2 to a very small extent, thanks to the placenta. The placenta protects the baby from hyperoxia very well. So it tends to reduce that. It all depends on if the mom is hypoxic or not. If the mom is not hypoxic and is perfectly okay to begin with, then giving oxygen actually doesn't help. And there is one study that shows that the umbilical arterial pH may actually go down if you use too much oxygen in the mother. On the other hand, if the mother herself is a bit hypoxic, if let's say her SATs are 89 or 90, and if she gets oxygen, then there is benefit in that case. So if the mom is hypoxic, then by all means, the mom should get oxygen. But the mom is not hypoxic and has totally normal saturations. Remember, pregnant mother saturation, normal saturation is 100%. It's much higher than an adult male. Pregnant moms tend to run very high sats. Their PaO2s are in the 100 millimeters of mercury plus range, whereas our PaO2s are somewhere in the 70 to 80 range. So moms have very high saturations. And if they are normally having good saturations, then giving oxygen doesn't help. On the other hand, if they're hypoxic, it helps. And there are studies to show that when mom's oxygenation is normal to begin with, giving more oxygen doesn't help with fetal distress, and in fact can cause the umbilical arterial pH to be a little on the low side. But that's a different story. But it's a common practice everywhere. Great.
No more questions here. May I ask Dr. Nirmala ma'am to have a few words on this?
Sir, excellent talk, and we have seniors in the session. Tilak sir, we have Dr. Alok Gupta ji and Tilak sir, Dr. Usha madam. So your comments?
It's a very important message has been conveyed that we should not aim for a 99 to 100% oxygen saturation in all conditions. And it should be limited and very calculated amount of oxygen which should be delivered to the newborn or the neonate. So this is very important that oxygen concentrations
Bit louder, sir. We are
monitored according to the need. Wonderful. Excellent.
I know it's late for all of you. It's almost 10, it's past 10 p.m. now. So
It's 10 p.m. for us.
Oxygen use in the NICU. Any new thoughts?
Oh, there's a lot on that topic. I actually have that. There's only half of my talk. There is one more half here.
Yeah.
So the total topic is on that only.
Yeah, no, somebody has put in the chat box. I think we will have another session about oxygen in the NICU.
Yes, sir.
Another session, I think.
Yes, ma'am. We'll have another session.
It's a wonderful session that we have today regarding the oxygen in preemies, depending upon the gestational age. It's an eye-opener for us all, for me at least, regarding the SAT percentage, depending upon the gestational age group. That was a very eye-opener, and how the babies' SATs make a difference in the outcomes and its effects, and the oxidative stress and the risk of leukemia. That was a very good point that I had come to know. Thank you very much, sir, for coming over and accepting our invitation, and looking forward to many more sessions from you.
Thank you, madam. Thank you so much. I really
With a
appreciate
short
it. Have a
duration
great
of
day.
information.
Thank you.
Short
Have a
duration
good night.
with a short duration of information.
Oh,
May I ask
thank you.
Dr. Vijayan to have a few words?
So I think, so what can I say? Whenever we listen to Satyan sir, usually I've met quite a few professors in Europe and in New Zealand. Generally, the moment we say professors, we get an impression that, oh, too much and complicated and lot more than a common people or a practicing clinicians take. But the greatness of Satyan sir is he makes so simple, and he makes you think with those simple terms. He doesn't leave you there, but he takes you to make you think. The real learning is a learning which not only answer your questions, but also generate new questions. Whenever we listen to him, he make us to generate new questions, and such a lucid way, such a graphic way, and he strongly believes that probably not one picture is words of 1,000 words, maybe million words or lot more. So, sir, so much to learn from you, sir. And the message I would take from sir's the session today, and for all of us, anything in life, measured action is the right way to react to any situation in life. Measured action. And oxygen in neonatology is no exception. Moderation is the way forward. Thank you so much, sir. మీకు మనస్ఫూర్తి అభినందనలు, కృతజ్ఞతలు. మళ్ళీ మళ్ళీ మా సెషన్స్కి మీరు రావాలని మిమ్మల్ని మేము మనసారా కోరుకుంటున్నాము.
Sir,
చాలా థ్యాంక్స్ అండి. తప్పకుండా వస్తాను. Last one tidbit. I grew up like many of you reading Chandamama, and for those of you who are as old as I am, there used to be two artists in Chandamama, Chitra and Sankar. Sankar used to draw the Fetal books, and I was a huge fan of Sankar, and I learned all illustrations from copying Chandamama pictures. So I really appreciate this opportunity. It's very nice to see all of you.
1 minute. 1 minute. Sir, here is a comment from Dr. Tilak Chandrapal, who is the senior most pediatrician. The excellent illustrations. That's what even I love, sir. That's what I was talking to you. We make all the PPTs taking your illustrations. Sir, anything from your side? Satyan, sir.
Oh, thanks, Andy. I really enjoyed the session. I look forward to meeting you all in person. So at some point, I really want to do a tour of Telangana and visit all the places I grew up in. So చాలా రోజులు అయింది భద్రాద్రి రాముడిని చూసి, so I will come there to visit him, and I'll come and visit you at that time. Thank you so much. Have a wonderful
So before closing this session, may I ask Dr. Tejo Pratap to say a vote of thanks?
Thank you, everyone, for attending. First of all, as usual, I think the Dr. Satyan sir talk is always stands out, even in the either in the conferences or in the as a webinar or anything. It's really good and always stands out, and we look forward to sir's talks every time. And as the saying goes, that Telugu people are more movie lovers. I think sir also will agree on the same, I think. So sir's talks are something like with those graphics and everything, and especially for people like me who enjoys the movies a lot, everything will goes into brain when you see the topic as one of the movie or anything. That's what I love to see the movies and other things. You told that Chandamama stories and other things, it always recollects our childhood and everything, and then how we enjoyed those reading those books and everything. So there are many seniors who have attended. Dr. Lok sir, Tilak Chandrapal sir, and I can see Dr. Prakash is also there. Prakash Manikot sir is there, and then some of the senior pediatricians are also, some of the senior neonatologists from Hyderabad group, Sriram, Lakshman, Nitasha is there, and many people are there. it shows that lot of interest, and I can see some of them are from outside the India also today. So somebody from Nepal and everything has messaged. So that shows that interest on this topic. And again, as everyone said, that oxygen is a drug and we need to use it in moderation. It has both the pros and cons. So that's what we need to look forward to. With all these comments, I think I would like to thank all the people who are work behind the scene for this webinar, and also with the help of Dr. Nirmala Madam, we are conducting all these webinars under NNF Telangana Forum with the help of Dr. Lingareddy sir and Surendranath sir. Thank you very much, sir. Satyan sir. Have a good day. That's what I can say for you. And for us, it's a good night. Thank you, sir. Okay.
Yeah, some other day we will talk about
another session
how.
on oxygen in ICU. Sorry, sir. Sorry.
Sure. Yeah. So we'll talk about something different, and then I'm a huge fan of movies, and I have watched Adivi Ramadu like 10 times, Yamagola like 50 times. So let's not go there. It's a different day for a different story. Talk to you later. Bye.
Thank you.
Thank you, everyone, and we'll call it a day.
Thank you. Thank you.
Yeah, thank you.